This explainer was written and edited by Dr. Thomas Hocker, a triple board-certified, Harvard and Mayo Clinic-trained dermatologist, Mohs surgeon, and dermatopathologist.
Immune suppression changes the odds in the care pathway, but it does not decide the fate of one tumor by itself.
But wait, hold on a second. You might be looking at this and wondering, how do these two totally distinct patients actually experience different risk assessments and clinical pathways for the exact same type of cancer?
This explainer was written and edited by Dr. Thomas Hocker, a triple board-certified Harvard and Mayo Clinic-trained dermatologist, Mohs surgeon, and dermatopathologist. Okay, let's just dive right in. The main reason a patient's immune status completely changes the conversation around cutaneous squamous cell carcinoma, or SCC, really comes down to how often the cancer occurs and how it behaves over time.
Just take a look at this number. After a solid organ transplant, ACCSC becomes massively more common. A 2024 meta-analysis, which was this huge review pooling data from 67 different studies, estimated a standardized incidence ratio of 45.9. So what does that actually mean for us? Well, it means that on average, across this vast data set, solid organ transplant recipients were developing these skin cancers at nearly 46 times the rate of the general population.
But here's the catch, and it's a really important one regarding how we interpret this data. That 45.9 multiplier, it's a population estimate. It is not an individual prediction, and it definitely doesn't dictate your specific destiny. The actual individual study estimates ranged wildly, from roughly 5-fold to literally more than 200-fold. Things like the specific organ you received, your latitude, your skin type, your exact medication regimen, the era of the transplant, and the time since the surgery, all of that completely changes the number. Throwing around a single universal multiplier is actually pretty misleading. What we really must focus on in the real world is cumulative tumor burden. It's simple math, really. A patient might develop multiple tumors over time, and more tumors just naturally increase the chance that one of them will carry aggressive features, which is exactly why prevention, surveillance, and care coordination become absolutely vital, rather than just panicking over a single universal risk number.
Now you might be asking, does this mean all immune suppression is treated the exact same way? Are we only talking about solid organ transplant patients here? No, absolutely not. And that distinction completely dictates the care pathway. Sure, immune suppression can come from solid organ transplantation, but it also comes from blood cancers like chronic lymphocytic leukemia, stem cell transplants, HIV, or even the chronic immune-modifying medications used to treat autoimmune and inflammatory diseases. These distinct groups do not share one universal risk number, and they definitely don't share a one-size-fits-all treatment plan. Things like the underlying cause of the immune suppression, how deep that suppression is, the patient's prior skin cancer burden, and the tumor's own unique features all play a crucial role in calculating the actual risk. And because of this elevated, but again, highly variable risk, there are specific warning signs that completely change the cost of waiting around. We're talking about needing a prompt evaluation by a dermatologist for any lesion that's growing quickly, anything painful, tender, numb, or tingling, spots that are bleeding or repeatedly crusting, anything thick, firm, or horn-like, a non-healing sore, a spot recurring in a previously treated site, or a new lump in a nearby lymph node basin. Now, do these signs guarantee a lesion is dangerous? No, but they do abruptly alter the timeline. In an immunosuppressed patient, a changing or painful scaly spot is a medical question that demands an immediate answer. It is absolutely not just an ordinary sunspot you can ignore until your next checkup.
Let's loop back to our opening contrast for a second to see how this plays out. For our immunocompetent patient with just a single lower-risk CSCC, a straightforward, routine margin excision might be entirely appropriate. Simple, right? But for our solid organ transplant recipient dealing with repeated tumors, their immune status completely alters the landscape. It demands an earlier, much more deliberate evaluation across the board. This patient requires closer clinical coordination, a deeper pathology context to really look at differentiation and invasion depth, and a deliberate clinical, nodal, and nerve examination. When the risk profile is elevated, the skin tumor itself is really only one piece of the puzzle.
Higher population risk should trigger more deliberate evaluation and coordination, not fatalism, and not one automatic procedure for every tumor. But wait, if a patient is immunosuppressed and their overall risk is way higher, doesn't that just mean every single tumor automatically requires Mohs surgery to be safe? Do we just fast-track all of them straight to the surgical suite? Actually, no. Immune suppression is not an automatic command that every single SCC has to be treated with Mohs, regardless of the site or pathology.
What the clinician actually does is combine the patient's immune status with the tumor's specific size, depth, location, borders, recurrence history, nerve involvement, and that nodal examination we just mentioned. If we're seeing deep invasion, perineural invasion, or positive margins, okay, then the pathway changes. Mohs, or another complete margin method, is often considered when those features make leaving residual tumor behind especially costly. We might even use imaging like a CT scan to stage lymph nodes or an MRI if perineural spread is suspected, provided it actually impacts the care plan. But at the end of the day, the site, the pathology, and the patient's overall health still dictate the surgical choice.
And this deliberate, customized approach extends directly into surveillance and prevention too. Follow-up intervals have to reflect the individual's specific pace of new cancers, their unique tumor risk, and their immune status. Obviously, a patient popping up with repeated tumors requires much closer skin surveillance than someone with just one lower-risk lesion. But here's the thing, there is no randomized trial out there establishing one perfect, magical follow-up interval. Seeing someone every 3 months indefinitely is just not a universal rule for every single transplant recipient. Of course, UV protection remains absolutely foundational. We're talking clothing, seeking shade, and strictly avoiding tanning. We can also treat field cancerization, which are those broad areas of sun-damaged skin, with dermatologist-directed methods like topical 5-fluorouracil or photodynamic therapy to help knock down precancers. Just keep in mind, those surface treatments absolutely do not replace definitive treatment for an invasive, higher-risk SCC.
So what about prevention pills, though? You see so much online about nicotinamide. Does that actually work for transplant patients? Well, this is exactly why we have to be so incredibly careful with how we read clinical evidence. Yes, nicotinamide successfully reduced keratinocyte cancers in a high-risk immunocompetent trial. But the 2023 Entrance trial rigorously tested it in solid organ transplant recipients and found absolutely zero benefit. None. You simply cannot take an immunocompetent result and transfer it to transplant patients as if the two populations are totally interchangeable. We do have acitretin, which can reduce tumor burden in selected kidney transplant recipients who have repeated tumors, but the benefit fades away once you stop taking it, and it carries some pretty high side effects. Things like severe dryness, lipid and liver issues, and extremely strict pregnancy constraints, all of which heavily limit how often we can actually use it.
And this leads me to a critical, strict warning. Never, ever stop or change your anti-rejection or immune-modifying medicine just because of something you read online. For example, in selected kidney transplant recipients, shifting from a calcineurin inhibitor regimen over to sirolimus might actually reduce new CSCCs, but that trade-off is exceptionally real. Tolerability can be limited, and a massive individual participant meta-analysis actually identified increased mortality with that switch. So trying to reduce one risk can accidentally create a far more dangerous one. Any medication changes absolutely belong to a coordinated decision made directly with the transplant or prescribing team. Never do it independently.
Now, what happens when a tumor becomes advanced? Well, PD-1 checkpoint inhibitors, which are these powerful immunotherapy drugs that essentially take the brakes off the immune system, might be considered. A 2025 individual participant meta-analysis really highlights the dual reality of using these potent drugs. In a subgroup of transplant patients with CSCC, the objective response rate was 61%, which is a highly meaningful cancer response. However, the 6-month acute rejection rate for the transplanted organ was 23.3%, and across the broader transplant cohort, 1-year graft loss was over 18%. Now, there is some early promising data, like a small phase 1 study that used semiplimab alongside a very specific mTOR and steroid protocol, which showed a 46% response rate with 0 graft loss in 12 kidney recipients. But honestly, that's just too small to promise safety for everyone. The crucial point here is that immunotherapy can control the cancer but endanger the graft at the exact same time. Cancer control and organ protection require intense, multidisciplinary decisions.
Okay, so for a patient walking into the clinic tomorrow, what exactly should they bring to their next appointment to make sure this coordinated care actually happens? You need a very concrete, action-oriented checklist. First, bring the complete pathology report to the visit. And I mean the full document, not just the diagnosis name, so the clinician can actually assess depth, differentiation, nerve involvement, and the margins. Second, bring your exact medication list and tell your dermatologist precisely why you are immunosuppressed. Third, actively ask whether a nodal examination, imaging, radiation, or an oncology review is needed. Ask what follow-up interval actually fits your specific tumor burden. And above all else, keep the transplant or prescribing team involved before any medication change.
The one truly memorable takeaway from all this is that immune suppression is a reason for an earlier deliberate risk assessment. It is not a reason to assume every tumor will spread or that it automatically requires the same operation. As a neutral next step, make sure to speak to your transplant or prescribing team before ever altering a medication. And to explore the broader menu of both surgical and non-surgical procedures, you should check out our squamous cell carcinoma treatment options explainer next. Because ultimately, navigating skin cancer after a transplant isn't about memorizing one terrifying risk number, it's about asking the right questions. So, what conversation will you start with your care team tomorrow? Dr. Hocker created Skin Trust to provide free, evidence-based dermatology education and help patients and clinicians make clearer decisions together.